Dear friends, today we are going to discuss another important topic, interstitial lung disease. It's really a very broad topic uh, because interstitial lung disease may happen in newborn, childhood, adult, adolescent, any age. So covering all these things in a single video is difficult. So today I may be confined to interstitial lung disease. People who are interested go for the other video, interstitial lung disease in childhood. What is interstitial lung disease? As the name suggests, it is these are the diseases that primarily affect the interstitium. That is what anybody can answer. That is correct also. But it doesn't stop with interstitium alone. It also affects the alveoli and the distal air sacs. That is the reason why many people called this as a diffuse lung disease. But I think after that, many scientific publications started using only interstitial lung disease. So in our lecture, we are going to talk as only interstitial lung disease. As I already said, interstitial lung disease can happen in infancy, newborn, childhood, adults and all. And again, the etiology also different, may not be the same. Sometimes there may be overlap, but most of the times, for example, if anybody talk about the infant that is interstitial lung disease in infancy, you have to necessarily think of the surfactant problems or the lung growth problem. These are the very, very important causes. Whereas, if you want to talk about the interstitial lung disease in adults, many smoking related problems, particularly the IPF, interstitial pulmonary fibrosis, is very important. In the childhood, I think we can see almost all, starting from autoimmune problem, going as a complication of ILD, or LCH going complication of LD, hypersensitivity pneumonitis and all. I think this is not a strict compartment. It is only for a knowledge. For example, a child started with a surfactant problem may present in childhood also. So, for convenience sake, I am dividing into three. And again, one more point is ILD in infancy occurs during the growing phase of the lung. So, naturally, here the etiology or the presentation, everything is going to be different. And there are about 200 ILDs there. And in adults, it's a great topic. So, for convenience, today I am going to talk on interstitial lung disease of infancy. Coming to the pathophysiology, can you see this? This is the alveoli, this is the interstitium, this is the capillaries. Actually, alveolar epithelium, interstitium, and the capillary endothelium. Actually, here is the oxygen exchange takes place. Oxygen from the alveoli comes, carbon dioxide from the blood vessels go like that. Initially, there is some damage occurs in the alveolar epithelium. Wherever there is a injury or infection, there is a exaggerated immune response. And naturally, all the inflammatory cells, particularly the neutrophils, start pouring in. And finally, healing takes place. When there is a healing takes place, fibroblasts come, they lay down the collagen, and that cause fibrosis. But here, in interstitial lung disease, what does happen? It is not an organized fibrosis. There is something go for a scarring. Naturally, normally, the interstitial is a thin layer. That's the reason why oxygen and carbon dioxide takes place. Here, it becomes scar-like thing. So naturally, oxygen diffusion is compromised, reduced, and child may progressively suffer from hypoxia and related complications. Coming to the clinical features, I think though there may be a little variation in the presentation. For example, ILD in a newborn present with a respiratory distress. And ILD long-standing of a mild nature, they typically go with a clubbing and all. But generally, if you want to say clinical features, you have to look for all these things. Child initially start with a cough, dry cough, chronic cough. I think it's very difficult to suppress the cough. Child will be going on coughing. And there may be a tachypnea initially or exertional dyspnea. Later on, the child started developing a typical respiratory distress because of the progressive hypoxia. On examination, you can see the clubbing, failure to thrive, growth may be compromised. I think Velcro crackles, this is very typical for ILD. What is Velcro crackles? Actually, in ILD, both alveoli or interstitium become very thick. So during inspiration, you have to take a full inspiration or mount the pressure to open these collapsed alveoli. That is the reason why typically it will produce a sound that is called Velcro crackles. Actually, anybody who happen to see a case, kindly auscultate in the basis of the lung. You can hear the Velcro crackles and all. And finally, child go for a restricted lung problem and respiratory failure. Actually, this is a one landmark paper. I can say that, and he is a scientist. He done more than 259 diagnostic bronchoscopies. And those days, only adult they can go for biopsy and all. But Langston is a scientist who done more than 259 diagnostic bronchoscopy, and he tabulated what are the common causes. He tabulated surfactant dysfunctions, systemic diseases, and even in immunocompetent woes, there are some conditions lead to ILD. No doubt, environmental agents play a very, very important, and no doubt some drugs, radiotherapy and all. Yes, it's a very good paper. People interested to go and study this paper, Langston. It is published in 2009, I think. So for convenience, I divide interstitial lung disease in children into those typically happening in infants, those typically happening in childhood. And again, I'm telling it is only for a convenience. It is not a strict compartment. Don't think that what is happening in infants may not happen in childhood. Or sometimes even a childhood problem may even manifest in infancy. So it is only for your knowledge. Easy to remember. So today I may concentrate on this right box. What are the conditions that lead to ILD in infants? Look at the first 4 causes. They are all surfactant problem. And later, I think I'm going to show all these things in a different slide. And we are not going to touch upon causes that lead to ILD in childhood in this topic. Probably people interested, you can see my another video also. So today our topic of discussion is ILD in infancy. The most important case is surfactant dysfunction. Actually, you all know what is surfactant, and we are going to talk about that. And there are many proteins that helps in the formation of surfactant, function of surfactant, storage. So they naturally go for mutations. And once they go mutations, the surfactant become abnormal. And the function of surfactant is altered. And a child may go for, because once there is no surfactant, they go for a alveolar collapse. Naturally, there is an infection, then they go for a chronic lung problem or respiratory distress and all. And one more thing is, there are some conditions are specifically happening in infancy. I think this is a Langston study and all confirmed this. One is a neuroendocrine cell hyperplasia of infancy. Simply you can call it NEHI. Or another one condition is called pulmonary interstitial glycogenesis, PIG. I think these are the conditions typically happen in infancy. Moreover, these conditions have some better prognosis when compared to the previous classification, previous condition that I described. Again, another important thing what they observed in child, there is a child is a growing phase. See, they say the lung grows up to even 8 years, and so Sometimes the lung growth abnormalities also typically go for ILD, of which the most important thing is dysplasias, particularly that alveolar capillary dysplasia with misalignment or malalignment of the pulmonary veins. That is simply called as ACDMP and all. So again, this is the same slide. Why I have shown in the blue means these are the conditions that have a better prognosis. You all know ILD itself known for its mortality and morbidity, and still the diagnosis is very, very important because some conditions do have some relatively a better prognosis. Still, I am following one case. I am going to show about that. That is called neuroendocrine cell hyperplasia. That I will show that. And these are the conditions that typically happen 2 years, and we will discuss all these conditions one by one and all. Initially, we are going to start discussing about the surfactant problems, and you all know surfactant B, C, ABCA, there is APCA3 and NKX2. I think I am going to tell all these things, and these are the protection. These are the proteins, they go for the mutations that result in ILD. Coming to surfactant, surfactant is a mixture of lipids and proteins. That is 90% of the lipids, 10% of proteins. Among the lipids, the most important is dipalmityl phosphatidylcholine. That is very, very important. This, along with other unsaturated fats and cholesterol, plays a very important role. But 10% is by proteins. The proteins are SP, that is protein A, B, C, D. Here, A and D are not implicated with the surfactant function. They typically, A and D goes with the defense function of the respiratory system. Whereas surfactant B and C are implicated with the ILD because they are mainly doing act as they function as a surfactant. As I already said, surfactant reduces the alveolar surface tension, and if there is no surfactant, then there is alveoli go for collapse. And you all know, I already said there are several mutations are happening, and once all the alveoli get collapsed, naturally there is a immune response, infection, respiratory failure, chronic pneumonia, all these things are all happening. So that is the reason why you all know about the IRDS. Video studies, sometimes they will call as ARDS and IRDS. That is, in a newborn child, preterm child, when the surfactant is less, it is called for idiopathic respiratory distress syndrome. There we give some exogenous surfactant, we make them all right. But here, when the surfactant protein itself go for the mutation, it is very difficult to manage. Again, it doesn't stop with that. If you look at the surfactant metabolism, actually you all know surfactants are produced by type 2 cell, and that is alveolar epithelial cells, type 2. There are two types of cells, alveolar type 1, type 2, and type 1 is really form a very big membrane, and they take part in the oxygen carbon dioxide exchange. Whereas alveolar epithelial type cells is a cuboidal cells. Actually, they produce type 1 also, and they also synthesize surfactant, and all these things, I think you have to revise your knowledge. And alveolar macrophages helpful in recycling also. In addition to the surfactant protein, what I discussed, one thing is called APCA, ABCA or ABCA3. Some people call it APCA3. That is nothing but ATP binding cassette transport. It's a very big name. You all know CFTR gene, something like that. Cystic fibrosis transmembrane regulator gene, like that. There is a very big name, ATP binding cassette transport membrane A3. What is the function of that? This is the protein that naturally stores the surfactant. And so most commonly, when compared to that, this is the one that goes for genetic mutation frequently there than other conditions. So ATP binding cassette transport membrane, it is the most frequent cause of congenital surfactant deficiency, and the affected child started developing a respiratory distress very early after life, and they go for a respiratory failure, and most of the children may die even in the first year of life. And it is being shown that it is an autosomal recessive condition with 200 mutations. And sometimes some of the children may escape and they present as a chronic interstitial lung disease. Actually, this is a child I happened to saw along with my newborn colleagues and all. Child presented with a severe respiratory distress, grunting, hypoxia, other workup including echo and other things, sepsis workup and all normal. Child had a ventilator support for nearly a month. We all given so much exogenous surfactant and all. Finally, the genetic analysis done and with a next generation sequencing and APCA3 mutation has been confirmed. So far I have been talking about three different type of surfactant protein, namely surfactant B, APCA3, and surfactant C. Actually, among the three, surfactant B mutation is really a lethal one, and it presents as immediately. This is a term child, not a preterm. Term child presenting with a neonatal RDS, and they die within a year. If anybody calls you and 3 month, 4 month, child is not getting out of the incubator, and the child becomes day by day worsening in spite of ventilator support, I think these are the condition, and it has a lot of mutation, 40 mutations, and you have to go for sometimes genetic analysis to confirm. I already said APCA is the most frequent cause of ILD in infants, and it is also cause 60% death, and 200 mutations are reported. When compared to these things, surfactant C is a relatively better condition. I am telling, when compared to B and APCA3, it has a little better prognosis because it also present as a neonatal RDS. Sometimes some of the bronchiolitis, RSV bronchiolitis, you may diagnose as a child RSV bronchiolitis, the child may not respond to treatment at all. And these are the candidates, probably the underlying cause might be the surfactant C mutation. I think among the three, surfactant C mutation, child may live long, but making a diagnosis with the genetic studies help to follow these children and making a diagnosis. One more addition is NKX2 mutation. What is this? Actually, this is a very big mutation. Actually, the gene responsible for that is called sometime thyroid transcription factor 1 gene. Actually, during our embryo formation, this gene or this protein is responsible for many things. That is a differentiation of that is a tracheal bud from the foregut, and it also plays a very important role in the CNS and endocrines and all. That is the reason why children presenting with NKX2 proteins, they may also have some hypothyroidism or some CNS problem and all. This condition go as a dominant one. Any child presenting as a ILD along with hypothyroidism or along with other CNS manifestations like chorea, I think you can firmly think of this condition. And so far I have been talking about the 4 conditions. Of all these things, these conditions also sometimes I already said. And ILD child, this is one child, it also had hypothyroidism, also had a chorea-like movements. And later when we planned for our genetic studies, the child not cooperated and they got absconded. Coming to the diagnosis of infants, all the problems, particularly the surfactant related problems, starts are presenting with a severe respiratory distress from the date of birth, and they are resistant to conventional treatment. All these investigations might be useful. Even HRCT may say that the child is having a diffuse pulmonary infiltrates, sometimes ground glass, septal thickening, all these things and all. And sometimes bronchoalveolar lavage might be useful. I tell about the usefulness. But for example, surfactant problem, it may not be very useful. And when you suspect in a young infants, and here genetic studies plays a very important. If you suspect a very known disorders, go for next generation sequencing. And if you do not know anything, go for whole genome sequencing. There are some institutions, they still do lung biopsy and all. And I think this knowledge is very important because some people want to know whether their child is suffered from surfactant problem and all. Simply you send the blood sample for genetic studies, and I think this is going to be tomorrow or in coming days. I think genetic studies plays a major role in the diagnosis of surfactant related problems and all. I already talked a very important subject. Now we will go to some ILDs are very specific to infancy. I already said why this means. It is a growing period of the child. And even the interstitium, the God has given many things like neuroendocrine cells. They have some purpose. Actually, these neuroendocrine cells are supposed to function as oxygen sensors. And there is some glycogen also there. Somehow, some children have hyperplasia, and they present as a condition called neuroendocrine cell hyperplasia or pulmonary interstitial glycogenesis. I happen to treat these children. I'll show the slides of case studies. This child, actually, I saw the child around 1 year, I think. Before that, the child is admitted 3 times in various hospitals, and when I happened to see is a growth failure was there. Is a grown up child. It's not this same. This is a later photograph and all. And I think this child is constantly I am following, and the child's CT shows ground glass opacity, and then we planned. I think most of the parents may not agree for a lung biopsy, and those days I always make them. I think this has happened very long, about I think 15 years before or something like that, and I convinced them to go for a lung biopsy. That is a video assisted thoracoscopic lung biopsy, and the staining, Bombicin, this stain was positive. Whenever this is a positive stain, I think it may be a candidate for NEHI, neuroendocrine. Actually, they also reported the presence of neuroepithelial cells in the biopsy. Finally, the child was confirmed as a neuroendocrine cell hyperplasia of infancy. I think this is a child I am still following. Why I am telling is, once this is a good prognosis among all ILDs. NE has a very good prognosis, and I said what the literature says, symptoms after the initial turmoil tend to improve, and I think this still the child is coming. Probably he had some exacerbation sometime, and I'll give simply hydroxychloroquine, or sometime I'll give very short course of steroids, and I think this I think still I explained everything about the mother, but still mother is very she want to protect the child all the way. She traveled for a long time, they came to see us and all, and only thing is, if you know that only we'll have a correct diagnosis, correct treatment. Otherwise, mother doesn't want to go anywhere because they're unnecessarily using very high antibiotics and all. And now child is made a diagnosis, and I think I already said no, that neuroendocrine cells, they're all function as a sensor or chemoreceptors for oxygen and all. And here these conditions now, I think even genetic studies also sometimes is going to be useful. Coming to the another condition, that is PIG. Sometimes it is called pulmonary interstitial glycogenesis. Actually, here if you see the interstitium, the interstitial cells are filled with glycogen. Abundance of glycogen will be seen as seen in the biopsy. And these also another condition like NEHI presenting from the infancy. Sometimes they may be associated with heart disease, very severe pulmonary hypertension. And like NEHI, I think this child also, when compared to NEHI, this is a one that definitely have a very good response to corticosteroids. Even NEHI may not have such a response. Here corticosteroids response is very good, and it's have a favorable prognosis also. And if you happen to do a biopsy and it is a Vimentin, it is a positive. Actually, this knowledge is very important because when you decide to go for or work for such children, and you have to discuss with the pathologist what you are looking for. Madam, I am looking for NEHI or P. Then you can use either a Bombicin strain or Vimentin strain or PS strain. Sometimes the staining itself make a diagnosis and all. Coming to the third important cause of ILD in infancy, these are grouped as developmental disorders of the lung growth. Actually, what they say, there is a hyperplasia or dysplasia of the alveoli or acinas or the veins. So I think there are it has some subcategories also. But the most common is alveolar capillary dysplasia with malalignment of pulmonary vein. It is very actually I happen to see one of the cases also. Actually, we don't know what is happening in this group unless we do study a lot of children. I think putting a categorical statement, this is a lung biopsy finding, and only if you make some large studies only we have to come like that. And I am lucky to have follow these children, roughly 20 children I followed in 2004. And actually, since being a public hospital I worked there, we always get a very severe cases of ILD, and the mean survival duration is 2.5 years only. And to our knowledge, I think we have done ball for all children. Many of the children shows neutrophils, and many of them I presented as either as a acute interstitial pneumonia, or it is also called Hammond-Rich syndrome, or non-specific interstitial pneumonia. Those days, it is not possible to do any genetic studies and all, and during 2004 and all, we have a limited resources, and most of them we clubbed as ILD or childhood ILD, or sometimes is acute interstitial pneumonia like Hammond-Rich syndrome, and most of them found to be having a severe hypertension. We published this also. It is one of the very early paper that appeared, and I already been talking about that. Many of our children may be fit into the category of alveolar capillary dysplasia with malalignment of pulmonary veins, because most of them are resistant to treatment and they also died. And there is a these children have some sort of a associated problem also. Actually, if we look at that a pathology specimen, there is a drastic reduction of alveoli and also the bronchioles and all. Majority of children is presenting with a pulmonary hypertension also, I think. And what they say, these are the conditions are implicated with a defective FOXF1 protein and all. I think it's a great subject. I don't want to go into that. And many proteins are very important during the embryonic period. And once they go for a mutation, we got many problem, either not only with the lung, many times lung problem may be associated with a gastrointestinal or genitourinary problem, or even cardiac problem also. So this is the last slide. Interstitial lung disease of infancy. Most of the ILD in infancy present with a severe respiratory distress, requiring ventilatory support, and the respiratory failure, they are resistant to treatment. And there are some conditions we can diagnose, because most of them due to surfactant mutations. So naturally you have to go for some of the genetics testing to confirm. Some of the conditions, if we are not able to find out by genetic testing, you have to go for biopsy to confirm lung growth abnormalities. And again, though it is a ILD in infancy is a very high mortality and morbidity, there are some conditions like NIHI, neuroendocrine, hyperplasia of infancy, and pulmonary interstitial PIG. These two conditions, in addition to surfactancy, all these conditions are relatively a better prognosis. I still follow one or two child and all. So I think making a diagnosis is very important. For that, today in this category, that genetic testing plays a very important role, and you can also use immunohistochemical staining. That also helps a lot. Thank you very much. People who are interested to know more about ILD, kindly refer my another talk on interstitial lung disease in childhood. Thank you very much. See you again.